Okay, so you get a lab report back on your desk. You glance at the CBC, and the platelet count is, well, it's astronomically high. What's the first thing that should pop into your head? Especially for board exams, one answer should be right at the top of your list: essential thrombocytosis. In this explainer, we are going to crack open this myeloproliferative neoplasm and give you all the high-yield clues you need to solve this clinical puzzle every single time. So let's imagine this exact scenario. You're reviewing labs and you see a platelet count of 2 million. I mean, let that sink in. 2 million. That's a number that just jumps off the page at you, right? This isn't just a little high, it's a massive, massive overproduction. So where do you even start building your differential? This is precisely the kind of hook you're going to see on an exam, and our goal today is to give you a clear, structured way to think through it. So at the very top of that differential has to be essential thrombocytosis, or ET for short. So what is it, really? Well, it's a myeloproliferative neoplasm, which I know is a mouthful, but all it means is that the bone marrow's production line is basically stuck in overdrive. And specifically, the part of the factory that makes platelets, these cells called megakaryocytes, is just churning out product nonstop. The end result? A sustained, ridiculously high platelet count. Now, what's really important here is to understand the molecular why. This isn't just happening for no reason. It's driven by very specific genetic mutations. For your exams, you absolutely positively have to know these three: JAK2, which you'll find in over half the cases, and then CALR and MPL. Think of these mutations as the faulty on switch that's telling that megakaryocyte factory in the bone marrow to just keep going and going. Okay, so we've got the what and the why down. Now let's get into the who and the how. What does the classic ET patient look like when they walk into your clinic? Or actually, what's much more likely is, what does their routine lab work look like? Your typical patient is often in their 50s or 60s, and it's just a little more common in women. But here's the really crucial point. It's usually found by accident. The patient feels totally fine, they go in for a routine checkup, get some blood work, and bam, the platelet count is through the roof. If they do have any physical signs, you might feel an enlarged spleen in about a quarter of patients. But the biggest clinical problem, the thing we are most worried about, is thrombosis. Blood clots. That's the real danger here. And while a lot of patients don't have any symptoms, if they do have them, there's one that is a total classic buzzword for your exam. You have to know this one. It's called erythromelalgia. And it's exactly what it sounds like: a really painful, burning feeling in the hands, sometimes the feet, along with this noticeable redness. But here's the diagnostic kicker, and honestly, this is a gift on any test question. It gets better with aspirin. If you see that in a patient vignette, burning red hands that feel better with aspirin, your mind should immediately be screaming myeloproliferative neoplasm like ET. All right, so we're suspicious. The clinical picture is starting to come together. Now, let's look at the hard data that's going to help us crack this case wide open. How do we use the lab to really nail down the diagnosis? First and foremost, you gotta look at that platelet count itself. The hallmark, the defining feature of ET is thrombocytosis, and it can be absolutely extreme. I mean, we're talking counts that can easily blow past 2 million. This is not a subtle finding, it's the whole ballgame. This table right here, this is basically your diagnostic checklist, so let's run through it. Platelets, markedly elevated, check. White blood cells? Maybe a little high, but often totally normal. Now here's the super critical part. Hematocrit and red blood cell mass, normal. Check that box twice. There is no polycythemia, and that's a huge distinction we're going to come back to. Then, if you do a bone marrow biopsy, you'll see exactly what you expect, just a sea of those platelet-making megakaryocytes. Okay, everybody, listen up, because this is, without a doubt, the most important section for your exams. A crazy high platelet count is not unique to ET. You have to be able to tell it apart from its look-alike cousins in the myeloproliferative family. So let's break down exactly how you do that. So the million-dollar question is this: is this isolated, crazy high platelet count from ET, or is it just one feature of another MPN, like CML, polycythemia vera, or even primary myelofibrosis? Let's go through them one by one and figure out how to tell them apart. First up, ET versus CML. This is the easiest distinction and the one you will definitely see tested. It all comes down to one single thing: the Philadelphia chromosome, also known as the BCR-ABL fusion gene. In ET, it's negative. It's not there. In CML, it's positive. It's a simple yes or no question that completely changes the diagnosis. Next up, how do we separate ET from polycythemia vera, or PV? The biggest clue is right there in the name. Polycythemia literally means too many red blood cells. So in ET, your red blood cell count and hematocrit are normal. In PV, they are elevated. That's the key difference. ET is all about the platelets, PV is about the red cells, even though platelets can be high there too. And finally, how do we distinguish ET from primary myelofibrosis? For this one, you need to look closely at a peripheral blood smear. In ET, the red blood cells look pretty normal. But in myelofibrosis, the bone marrow is getting all scarred and fibrotic. Think of it like a sponge that's slowly turning into a rock. As those poor red blood cells get squeezed out of that scarred marrow, they get misshapen. And that's where you get those classic teardrop cells. See those? And you know it's not ET. So, we've worked through the presentation, we've nailed down the labs, and we've ruled out all the lookalikes. We have our diagnosis. It is essential thrombocytosis. So, now what? What's the plan? Treatment is all about risk. We want to prevent that number one complication we talked about, which is thrombosis or blood clots. So, who's at high risk? Well, we look for three things. Are they over 60 years old? Have they had a blood clot before? Or do they have that JAK2 mutation? If a patient checks any of those boxes, they're considered high risk, and they're going to need therapy to bring that platelet count down. The treatment plan, thankfully, is pretty straightforward. Step 1, what's our goal? We want to get that platelet count down to a much safer level, usually under 500,000. Step 2, how do we do it? The go-to medication for this is an oral drug called hydroxyurea. And step 3, for those specific symptoms like the burning hands, a simple low-dose aspirin works like a charm. So what's the outlook? Well, the good news is that ET is generally what we call an indolent disorder. It's slow-moving. The average survival is actually more than 15 years, which is great. The main day-to-day issue remains the risk of thrombosis, but we do have to keep an eye on some long-term risks. Over time, there's a 10 to 15% chance it can progress to myelofibrosis and a smaller 1 to 5% risk of transforming into acute leukemia. So let's bring it all home. The next time you're faced with that lab report showing an astronomical platelet count, you'll know exactly what to do. You'll run through the checklist. Is it isolated? Is the Philadelphia chromosome negative? Is the red blood cell count normal? If the answer is yes, yes, and yes, then you know what should be at the very top of your list: essential thrombocytosis. Master that simple formula, and you have absolutely mastered this high-yield topic.